Good evening, and thank you for joining us. I'm Dr. Alan Kaplan, CEO of UW Health. Welcome to our 2021 Wisconsin Medicine Livestream series. We will be bringing you programs one every other Wednesday evening now until June. Tonight's program focuses on addiction. Addictions to both legal and illegal products. Apart from tobacco, substance abuse disorders affect 15 to 20% of Americans over their lifetime. Moreover, about 14% of adults suffer from tobacco dependence. In total, addictions account for more than 700,000 deaths each year in the United States, most of them from tobacco use. The economic costs exceed $500 billion each year, including the impact on health, lost productivity, child welfare, and criminal justice. While that figure may be shocking, it still doesn't adequately communicate the suffering experienced by individuals, families, and communities in Wisconsin and beyond, suffering an impact that has only escalated during the course of the COVID-19 pandemic. Addressing this crisis requires innovation and creative solutions on the fronts of both treatment and prevention. Scientists at UW Health and the School of Medicine and Public Health are leading the efforts to more effectively prevent and intervene to improve health and well-being in Wisconsin and beyond. First up, I'm pleased to introduce Dr. Randall Brown. Dr. Brown is an associate professor in the Department of Family Medicine and Community Health at the University of Wisconsin School of Medicine and Public Health. He leads a number of programs, including Director of the Program for Research, Outreach, Therapeutics, and Education in Addictions, and Director of the UW Addiction Medicine Fellowship Program. Welcome, Dr. Brown.
All right, thank you, Dr. Kaplan, for the kind introduction, and thanks to you, Dean Golden, and the School of Medicine and Public Health for the invitation to be here with everyone this evening and talk about work in the addiction medicine program at the University of Wisconsin. So, Dr. Kaplan touched on some of the broad issues, the scope of the problem that we face when it comes to alcohol, tobacco, and other substance use issues in the United States. But I want to provide a few other pieces of information that really inform a lot of the work that my lab does. When we talk about substance use disorders, and I'll be focusing on alcohol and other drugs aside from tobacco, we're really in a situation with that level of prevalence where we can't expect to lean on sort of the traditional, the conventional specialist substance use treatment agencies to get us out of this. There simply isn't capacity in geography, and they aren't equipped, or trained, for instance, in issues around prevention. And so, which represents missed opportunities for screening, prevention, and treatment if we're not dealing with this on a number of fronts in healthcare and beyond. Perhaps tragically, we were missing these issues quite a bit in general healthcare settings. Fully 30% of individuals making contact with primary care and hospital care in the United States at the time of their presentation are struggling with risky substance use or problem substance use. And 2/3 of individuals struggling with such an issue over the course of the year are going to make contact with general medical settings. But even when they do, they're accessing evidence-based care for their issue less than 10% of the time after those contacts. So some of that is likely a function of the exposure that we get during our medical training. Over 4 years of medical school, 3 years primary residency, and tens of thousands of hours. On average, a physician, as a healthcare professional, for example, receives on average less than 10 hours of formal curriculum addressing substance use issues. And so in our addiction medicine programming in my lab, we're really looking to move the needle on health services in general medical settings and innovate what's being done in terms of prevention as well as treatment in settings outside of specialist treatment, so that we can really broaden systemically the impact that we might have on substance use and the harms attributable to them. So, and in that spirit, we're engaged in a number of efforts, as our acronym might communicate, on the fronts of research, community engaged work and outreach, clinical care, therapeutics, as well as education. Our research sort of falls into two arms or camps. I do a lot, my colleagues, we do a lot around health services, sort of looking to investigate systems around screening, prevention, and treatment that are feasibly implemented in primary care and hospital settings that might reduce harms attributable to substance use, help individuals struggling with their substance use move down the pathway to recovery. We also do quite a bit of work by way of clinical trials, looking into innovative pharmacotherapies that might help people better engage in a program of recovery and move toward full remission. We do a lot of work in the community statewide. I made mention of the fact that a lot of providers don't have enough training to go into practice and feel really comfortable dealing with these issues. So we do a lot of work with primary care providers around the state through what we call our ECHO project, where we do twice monthly educational sessions that are case-based, that primary care providers around the state bring in and attended by other primary care providers as well as experts, and do some education around how we can effectively manage some of these issues in primary care. And it can be done effectively in primary care, and a large body of literature tells us that. We're innovating settings where care can occur, doing more of this with experts housed in primary care settings and at UW Hospital, and in other settings where individuals may be more likely to be struggling with their substance use, such as HIV clinic and pain clinic. We established one of the first training programs formally accredited in addiction medicine for physicians who have already completed another primary residency program, such as family medicine or internal medicine. And we do a lot by way of other educational efforts with other schools within the health professions and beyond in graduate and undergraduate education. And we don't have enough time for me to fully recognize everyone in our shop that contributes to this important work. Wish I did. It's a wonderful group of people doing wonderful work that they're passionate about to try to innovate these systems, democratize knowledge, and get multiple sectors of society more comfortable with prevention and treatment when it comes to substance use disorders, associated conditions, and the impact that they have on individuals, communities, and families. So I've given you some of the broad strokes, and I thought I'd provide just a couple examples of the research that we're doing. To start with an example in our health services line of work, our STOMP project is screening and trauma for opioid misuse prevention. We recruited 295 patients at UW Hospital on the trauma and orthopedic surgery services, and did a number of measures around their mental health and substance use history, their social support, factors around their injury, and then followed them forward for 6 months, taking more measures along the way. The idea being, we wondered if we could identify particular factors of risk during the time of their hospital stay that might predict struggles with their opioid use going forward. It might give us some insights as to how we might better support those individuals and intervene early if they are starting to perhaps have some struggles with their opioid use as their pain from their injury is being managed. And we were fairly excited about findings from this initial study that we hope is going to lead to a lot of other work to really shore up what we're doing in healthcare here. The graph that you're seeing up here is what's called a receiver operating curve, and that's a common tool used to relay information about the effectiveness of a screening test. And what it conveys basically is a perfect screening test where positive and negative results are both really helpful. The number under that curve, the area under that curve is 1.0. As you can see here, we achieved about a 0.97. Which we're really excited about. You know, when you look at that value for a number of other routinely recommended health maintenance examinations, you know, a number of them are more in the 0.6 to 0.8 ballpark. And the things we found that were strongly predictive may already be coming to mind for some of you. Individuals that were struggling with anxiety prior to their injury, that struggle with pain coping and the stress that pain is causing them seem to be particularly vulnerable. And so we have hopes for moving these findings further, coming up with interventions early that might assist in reducing opioid misuse in the context of continuing effective pain control, which is, of course, important in this setting as well. By way of a clinical trials example, I thought I'd talk a little bit about some innovative therapies in which we're involved investigating, and at which University of Wisconsin is really at the vanguard. This burgeoning area of science is psychedelic therapeutics, where MDMA and psilocybin are being actively investigated for a number of very difficult to treat mental health conditions as well as substance use disorders. And we collaborate with peer institutions such as Johns Hopkins, NYU, University of British Columbia. But this is a trial by way of example that we initiated here at University of Wisconsin, and is first of its kind, looking at the potential for psilocybin as adjunctive treatment for opioid use disorder or opioid addiction. And so you may know there are already medical therapies out there that are FDA approved, and they are helpful. They do save lives. They reduce transmission of hepatitis C, HIV, but there's still some struggles around maintaining that treatment, keeping individuals engaged in ongoing substance use. And we're interested in whether supervised administration of psilocybin laid upon behavioral treatment may facilitate psychological shifts that facilitate longer-term retention and treatment and a different kind of approach to recovery. So what we're going to be doing is recruiting 10 individuals who are on an accepted therapy, buprenorphine, Suboxone is a commonly known name, and administering, again, under supervised conditions, psilocybin on 2 occasions separated by 4 weeks. And we'll be double checking on any potential interaction between psilocybin and buprenorphine, as well as taking some measurements over 2 months' time to see if there are shifts in approach to treatment, craving for opioid, use of opioids, use of other substances, and other measures of their functional status. I've already gone into this a little bit, but I'm also just putting up information on clinicaltrials.gov. This is a trial that you'd be able to find with this search if you want a little more detail about the methods behind the study that I'm talking a little bit about here. This does take a small village to run, as you might imagine. There's extensive behavioral therapeutic support with licensed mental health professionals during the course of assessment, screening, and they're also present during the day of dosing, medical supervision, and of course our research coordinators that do so much of the work guiding participants through the research and collecting the information that's going to let us know about the effectiveness of this potential intervention. Past studies, of which there are numerous that have engaged in research around these compounds, emphasize this importance around set and setting and screening people appropriately to minimize risk, establishing rapport, orienting them to the session, and having the session take place in a comfortable environment, because it can be quite a long day between the assessments and the dosing session itself, 8 to 10 hours or so. And this is our session room in the School of Pharmacy that was funded by the Linton Innovation Fund. So we're very thankful to them for that. So I already made mention of some of these things in terms of the supervised dosing, separated by 4 weeks. We do keep an eye on folks overnight as well on the clinical research unit at University Hospital. And I made mention of some of the things that we're following up over time on a weekly basis thereafter. So we're excited about those results. We're currently recruiting for that study. And these are just some examples of efforts that we have on the horizon. Made mention of following up on our STOMP study. We're doing a lot of work in Wisconsin's rural areas. Substance use disorders are not uniquely an urban issue, and access can really be challenging in some of those areas. We have trial on tap that we're collaborating with Johns Hopkins and NYU on for psilocybin in the setting of alcohol use disorder, among some other things. So thanks again for inviting me to be here, and hope you enjoyed what I presented here, and I'll look forward to taking questions later.
Great. Thank you, Dr. Brown. And I think it's important to acknowledge the impact that you have as an individual in both directly treating individuals with addiction, training additional providers, and expanding our knowledge so that we may be more effective in the future dealing with these horrible problems. At this point, I'd like to introduce Dr. Michael Fiore. Dr. Fiore is the University of Wisconsin Hilldale Professor of Medicine at the University of Wisconsin School of Medicine and Public Health. He is founder and director of the University of Wisconsin Center for Tobacco Research and Intervention. Welcome, Dr. Fiore.
Thanks, Dr. Kaplan. I'm pleased to have the chance to talk tonight about something that would have been unimaginable just a few years ago, and that's the elimination of tobacco use from our society. Before I do, though, I'd like to talk a little bit about the Center for Tobacco Research and Intervention. CTRI, as we refer to it, is made up of over 50 individuals who work together to reduce tobacco use. That's our mission. We were founded in 1992. We have offices across Wisconsin because people smoke across our state. Our activities include studying ways to help people quit smoking, how we take those findings to clinicians so that they can help their patients to quit. We run the Wisconsin Tobacco Quit Line, a free telephone service available to anyone in our state at 1-800-QUIT-NOW, where an individual can get a live counselor who will work with them 24 hours a day, 7 days a week to help them to quit. Over 300,000 Wisconsin smokers have already called. And we're very engaged in policy work, knowing that if we create an environment that encourages people to quit, they're more likely to do so. We're funded by the NIH from UW Health and UW Medical School foundations, and of course, through philanthropic contributions. So this slide shows smoking rates over the last 60 years, and it represents truly a public health success story. We have overseen the decline in smoking rates from their peaks in 1950s of almost 45% to about 14% today. A remarkable achievement that rivals any medical success of the last century. But with that success, we still have over 34 million adults in the United States who smoke. And if they don't successfully quit, half of them, over 15 million of them, are going to die prematurely of a disease directly caused by their smoking, on average, robbing them of about 10 years of life. And while smoking rates have declined, and that truly represents a success story, the people who continue to smoke in 2021 are among those with the least resources. Highest smoking rates are seen among the poor, among those with the least education, among those who are addicted to other substances, and particularly among individuals with mental health diagnoses. We also see very high smoking rates among certain racial and ethnic groups, particularly Native Americans here in Wisconsin. Moreover, while this represents enormous progress showing this decline in smoking from about 45% to 14% today, if we take that curve forward, it's going to take until about 2050 to eliminate tobacco use. Thus, our challenge remains, how do we bend that curve? How do we advance progress so that we can achieve the elimination of tobacco use by the end of this decade? The health and economic costs associated with smoking are really unrivaled. We know that smoking directly causes 13 different types of cancer, that 1 out of 3 cancer deaths are directly caused by smoking, including 90% of all lung cancer deaths. We're appropriately working so hard to find a cause for cancer when we have in front of us a cause for 1/3 of all cancer deaths, and that would be the elimination of tobacco use. Smoking also causes cardiovascular disease. It causes emphysema and chronic bronchitis. In total, almost 500,000 deaths per year, fully 20% of all deaths in America directly caused by smoking. And the economic costs as well are overwhelming, $300 billion in added healthcare and lost productivity costs. What can we do about this? I started by talking about what I believe is the capacity to eliminate smoking in America by 2030. Here are the strategies that I believe can lead to that success. First, we know that individuals are exquisitely sensitive to price, even though this is an addictive drug. We've found that for every 10% increase in the price of cigarettes, there's about a 4% decline in consumption. So by raising cigarette excise taxes, we encourage people to quit. And that also discourages young people from starting to smoke. We know that smoke-free policies make a difference. And here in Wisconsin, we have a smoke-free indoor ordinance that says every worker deserves to work in a site that is smoke-free. Media campaigns that discourage smoking, and we've seen them from the CDC and the FDA, have a big impact. And maybe the strategy that is most relevant and most within our grasp is to reduce the nicotine content of cigarettes to non-addictive levels. This received some media attention just over the last few days because we've found that people will not smoke denicotinized cigarettes. And the FDA has the authority to reduce the nicotine content to non-addictive levels. If that action was taken, we know that smoking rates within 1 year would fall from their current percent of about 14% to down to less than 5% of adults. Importantly, to take all of these actions need at the same time providing cessation treatments to all smokers who want to quit, because if we take away the access to nicotine that kills them, which is nicotine in cigarettes, where there's more than 5,000 other chemicals, 50 of which are carcinogens, we need to give them an alternative, and we can do that with evidence-based cessation treatments. As a society back in the 1950s, we mobilized to confront another epidemic, and that was the epidemic of polio. Over the course of just a couple years, we developed a polio vaccine, and we rapidly gave that vaccine to folks across our society, focusing on youth. What we did over the course of just a couple years was to immunize all adults and children and very rapidly eliminate polio from our society. Little did we realize that as polio was getting controlled, a new epidemic of tobacco dependence that would kill far more Americans would come to the fore. And just as we did back in the 50s against polio, we now have the chance to do the same against tobacco use. The elimination of this deadly product is within our grasp, and we at the University of Wisconsin Center for Tobacco Research and Intervention welcome the chance to be part of this effort to eliminate this killer in our society.
Thank you, Dr. Fiore. You know, I think as I watch the presentation, the most astounding figure to me is the thought that while we spend millions of dollars on treatment, drugs, and research to find the cure for lung cancer, we can prevent 90% of cases just by stopping tobacco use. Extremely, it's just mind-boggling. Very important work that you do, and I admire your goals of stopping tobacco use across the country, because it's not like an instant return. It requires a lot of fortitude to keep at this year after year, as you have done, and you've dedicated your life and your career. So thank you for that. We do have a number of insightful questions that we have received during tonight's presentation, and I'd like to pose them to our panelists. Our first question this evening is for both Dr. Brown and Dr. Fiore, is what kind of impact has the isolation during the pandemic, what has it had on the addiction issues? And do you anticipate lasting impacts, either positive or negative? Why don't we start with Dr. Brown?
Yeah, great question. And we are starting to see findings in the literature around this indicating that some of these problems have increased fairly dramatically. Yeah, so far as alcohol goes, at least 20% of individuals in studies in the United States, UK, and Australia, 20% of individuals have increased their alcohol use. And not only that, but their perceived consequences of their use have also been increasing significantly. We also know that opioid overdose mortality has increased quite dramatically during the pandemic. And while we don't know completely the roots of that, a number of experts have theorized that that may have something to do with isolation, since, for example, someone might not be present during use to rescue someone in the setting of an overdose and administer naloxone. And then, of course, as the question contains, there's sort of the isolation and the stress and perhaps depression that creates, that we know is also associated with substance use and risky substance use.
Randy, that was really interesting. And it's a similar pattern with tobacco use in the United States. We know, for example, that if you smoke cigarettes, your risk of dying from COVID is about doubled than if you're not a smoker. So we need to get the message out to folks that one of the most powerful ways to survive COVID, if you get it, is to quit smoking. And just as with individuals using other substances, the isolation has led to some increased smoking in the United States. So that progress that I showed in the graph earlier has unfortunately flattened over the last year as a result of, we believe, the added stress and fear that's related to the pandemic.
Thank you. This next question is for Dr. Brown. Our viewers are interested in learning more about potential family connections with addiction. Specifically, is addiction an inherited trait?
Oh, great question. And yes, there is no denying that genetics are a powerful force when it comes to the risk for developing a use disorder or addiction. Fully 50% of the risk in use disorders is constitutional or genetically determined, with that remaining about 50% being due to environmental factors that we might intuit by way of childhood upbringing and experience with family and with friends and mental health issues and things along those lines. Yes, genetics and family history are incredibly important.
Great. Thank you. Great question. Great answer. Dr. Fiore, I could have asked this question myself because I'm very interested in this, is despite all the evidence and accepted understanding that smoking is deeply harmful, why has it taken so long to reduce the number of smokers? And both also with this is, where does nicotine fall in terms of being one of the most addictive drugs?
Well, why do people continue to smoke? Pure and simple, it's because that tobacco use is an incredibly addictive behavior. Most individuals become addicted in their early and mid-teens. We know that early tobacco use alters the brains in fundamental ways that puts people at risk of lifelong addiction. And this results in, frankly, just a monkey on the back of so many adults. There are a few people today who say, I smoke and I love it. Instead, they feel trapped. Virtually all have tried and have failed. And they're dependent upon a substance that they can't quit on their own. And that's why it's so important to have cessation options readily available. There's a stigma around smoking that this is just some bad habit that everyone should be able to overcome on their own. In fact, it's a powerful chronic disease, an addictive substance, and one that requires medical treatment just as any other does. So those are some of the reasons why people continue to smoke. It's a powerfully addictive substance.
Yeah, and if I could just add something really quickly to that, this is anecdotal, but I've been quite impressed in working with patients that have struggled with addiction to cocaine or even harder drugs who have come out of that and said to me, quitting cigarettes was harder.
Interesting. All right, the next question is for Dr. Brown. What are some of the signs that primary care providers should look for to help patients who may be suffering from addiction?
Oh, great question. How to answer that efficiently. So there are a number of screening tools that should routinely be getting used in primary care settings for tobacco and also for alcohol. We have less well accepted or universally accepted screening tools for other drug use, with the U.S. Preventive Services Task Force indicating to us we don't have enough evidence yet to tell us that that works well yet. And there are some exceptions to that. Universal screening is recommended during pregnancy, but there's still some work to be done there. And honestly, actually, I mean, I think the other thing that I draw attention to is when we think about screening and prevention for use disorders, one of the things that really actually works particularly well isn't specifically targeting the substance use itself, but is targeting the things upstream from there. So I think the efforts in which systems already routinely engage around screening for depression and anxiety and adverse childhood experiences are some examples of things that are going to start moving the needle on that as well. And beyond that, I mean, I think, there's certainly other circumstances where more targeted screening for folks at risk makes some sense. But otherwise, we're kind of looking for evidence of dysfunction, challenges in that person's life, and kind of tracing it back from there for the most part. And how that manifests, of course, is going to depend on age and a number of other factors. So
that's a great lead into our next question. And this has two parts, one for each of you. So for starting with Dr. Fiore, the question will be that you had talked about socioeconomic disparities in people who are current smokers? And is the approach to reduce smoking being approached as a social justice issue in addition to a public health issue? And then following that, very related, a viewer asked, this is for Dr. Brown afterwards, given increased racial disparities in addiction and opioid overdose, I'm wondering in what ways you are engaging with communities of color in your research.
So I'll start. I think that is a really powerful point about tobacco use increasingly being a social justice as well as public health and medical issue. To me, it is incumbent upon us in the medical field, but also beyond that, to really think about the fact that individuals with the least resources are now dependent upon a substance that is the most deadly one that most people encounter in their lifetime. I mentioned earlier that 50% of smokers will die prematurely of a disease directly caused by their smoking if they don't quit, on average, robbing them of 10 to 15 years of life. As a physician, there's virtually no disease I encounter that carries with it a 50% mortality rate. And the individuals who are bearing this burden are those with the least resources. I particularly think about it as a family issue. For too many families across Wisconsin, a loved one has been robbed of them early in their lives. And we talk so much about statistics and numbers and percentages, but for every one of these individuals who die prematurely, there's a son who lost a father. There's a brother who's lost a sibling. There's an individual who's lost a loved one. And when put in those personal terms, it really calls out to all of us to do what we can to help every individual dependent upon tobacco to quit.
Yeah, I mean, and yes, this is an incredibly important issue in the area of other drugs as well. And interestingly, honestly, most populations of color have substance use rates that are lower than the white population, but they tend to experience consequences more frequently. One example is the Native American, Alaska Native population, where actually, like, the rate of risky and problem drinking overall is actually lower, but within that population, among individuals who consume alcohol, there's a greater likelihood of experiencing longer term consequences for reasons that we don't understand entirely. And so far as, other consequences, by way of overdose, I might imagine that there might be issues around neighborhood disadvantage and environment that might contribute to that as well. And the ways in which we're reaching out to specifically answer some questions along those lines is we work quite closely with networks of federally qualified health centers in the state, and which is a lot of you may already know, clinic organizations that are specifically serving Medicaid and uninsured populations. So we're really reaching out, trying to provide education in those environments. And we also collaborate closely with community outreach agencies that are specifically targeting communities of color, including Madison Urban Ministry and Clinica Latina and Centro Hispano.
Great, thank you. Important work and important things to think about. Always have been, but even at a heightened level of interest lately and awareness. Dr. Fiore, how has vaping changed the demographics of nicotine use? And I'll just add, has this set back your goals at all?
Well, vaping has surely changed the landscape. This is a product that wasn't even around 10 years ago. And now we have upwards of 20 to 30% of our young people reporting that they used it either in the last 30 days or in the last year. So to just talk a little bit about vaping, because it's a really complex issue. What isn't complex is that we know that all children should be protected from vaping products. Vaping products contain nicotine. And as I mentioned earlier, nicotine fundamentally changes the brain in a way that puts individuals at risk for lifelong addiction. And there's powerful evidence now that kids who start by vaping often graduate to using cigarettes or combustible tobacco products, as they're often referred to, that carry with it a 50% mortality rate. What's more complicated is, what about adults? Because vaping products clearly are less dangerous than burning tobacco, but less dangerous does not mean safe. And for that reason, the idea of reducing nicotine products to non-addictive levels, cigarettes, cigars, smokeless tobacco products, and e-cigarettes or vaping products, is one way, via policy that's available to the FDA today, that we can potentially eliminate all of these harms, thereby protecting children from the deleterious effects that we know result in them using vaping products.
Great, thank you. I'm going to interject my own question, and this one's towards Dr. Brown. Are you seeing much integration of illicit drugs into the vaping technologies?
Well, cannabis and cannabis-related products have certainly gotten some press along those lines, particularly with mortalities related to some of those products. But I have not been hearing of other illicits coming into that form. I don't know if you have, Michael.
Well, we had an individual visit us at the Center for Tobacco Research and Intervention today from the National Institute on Drug Abuse, visiting us virtually. And he was talking about this very issue and the incredibly innovative and deadly ways that people are using vaping products to mix drugs. It includes often tobacco products, but tobacco products laced with, as you mentioned, Randy, cannabis, but other substances added. So the technology, just by itself, carries with it substantial risks, particularly among young people. And for that reason, it's of substantial concern.
Interesting. So this question is for both of you. How can friends and family members support people who may need to seek treatment but are resistant?
I can start with that, and that can be a fine line to walk, when it comes to alcohol and other substance use issues, where, a lot of people who work in the field will tell you that, until that person is ready to walk that path of recovery, the likelihood of success is fairly low. So I think the first place to start is always expressing your concern, that you care about them and that you're worried about this pattern and why. And if they are interested in seeking that help, assisting in ways that you can with them doing that, but also kind of having some boundaries around that relationship in terms of not seeing yourself as part of the treatment team. Certainly should be available, to support, but that can be, as I say, kind of a fine line to walk. Some of you may have heard of, orchestrating family interventions. And from what we know, for those to be successful, you probably really should seek out someone who's professionally involved in putting something like that together. and really doing your homework on that. If it's kind of getting to a point where you're feeling like something like that may be needed.
Great.
Yeah, many of the ways that you just described, Dr. Brown, apply to tobacco as well, with a few differences that I think warrant mentioning. First, tobacco use has been, and this has been supported by the tobacco industry, and they've done this really effectively, is to frame it as a habit rather than a chronic disease, a powerful addiction, something that people are doing that they don't really want to do. So to talk about it for what it is, a powerful addiction, a chronic disease, medicalizes it in a way that I think makes it a little easier for individuals who use tobacco to not feel as badly about it as they do, which brings me to the second issue. And that's something I think is the case with illicit use, but particularly is the case with smoking in 2021, and that is the shame around tobacco use. People who smoke today, for the most part, hate that they smoke. They hate the cost, they hate the smell, they hate what they're doing to their loved ones because of exposure to secondhand smoke, which by itself can be harmful. So to recognize that most people don't want to smoke. 50% try to quit every single year. And that brings me to the last thing that applies to both tobacco as well as alcohol and illicit drugs, and that is to let folks know that treatments are available. These are chronic medical conditions that warrant treatment. And for smoking, as I mentioned, anyone can call 1-800-QUIT-NOW and get access to free counselors who will also mail 2 weeks of free nicotine replacement therapy to the individual's home to get them started on a quit plan. In every health plan in Wisconsin and across the nation must, as part of the Affordable Care Act, cover the treatments for tobacco dependence. One last resource, anybody can go on the National Cancer Institute's website, www.smokefree.gov, and get access to a variety of free services, including text-based and other apps for people who want to try to quit using those resources.
Michael just reminded me of a couple other really quick, important things. The medical model, totally agree. And that's the other place where I'd encourage people to support, particularly in the setting of opioid addiction or opioid use disorders. If someone moving toward recovery is accepting of a medication for that, because I think there's sometimes a perception if someone is getting onto methadone or a buprenorphine preparation like Suboxone, well, aren't you just substituting one addiction for another? And no is the answer to that question, because when those medications are taken as prescribed for that condition, we know that they save lives, they enhance function and improve a number of other outcomes. And I won't, belabor sort of that point. And another resource, as Michael was mentioning others that I might throw out, is 211 Wisconsin. They have a website, 211 Wisconsin, or just dialing the number 211, you get access to a state hotline, as it were, with information on resources in whatever geographic area, and they can let you know what's available, what insurances they take, and things like that. And that is a patient and family facing resource. So
Great, thank you. Another question for both of you. Has support for these types of studies in clinical treatment settings kept up with the need? And how is the work funded?
Maybe I'll start. Unfortunately, it hasn't. And I think that applies to both tobacco as well as to alcohol and illicit drug use. When we look across our society at the health impacts of the challenges that Dr. Brown and I address, a small proportion of grant funding from the NIH and other funders goes to address this. So we work really hard to obtain funding from the National Institutes of Health, from philanthropic entities that offer such support, and also to the public, because so many of the grants that provide funding limit the way we could use that funding. And for much of the direct service that we want to give to people who are addicted, particularly those with the least resources, are not ones that are necessarily under the umbrella of a research study. So we apply for grants. We go to charities that offer such support. And finally, we ask the public to support our efforts as well.
Yeah, I think you summarized the situation really well, Michael. I don't have a lot to add to that. Yeah, the funding is not heavy. And I think another piece of evidence for that is you're not seeing a huge amount by way of research and development in large pharmaceutical industry in terms of developing new pharmacotherapies for these issues. And that's partly why another burgeoning area of research is looking into the possibilities for existing medications that have some other FDA approved indication and seeing if they might help for alcohol and other substance use disorders. It is an area of need.
Great. And Dr. Fiore, when you were speaking, I heard a siren in the background, which is a nice touch. I think we'll add these sound effects in our upcoming Wisconsin Medicine broadcast. So closing question for both of you. What makes you excited for the future of your work? Why are you so committed to what you do? And clearly, I know both of you are.
Right. Well, for my part, I've been at UW for 20 years. And one of the things that really excites me is how much more interest health professionals in training are taking in these fields. When I first came here in 2001, I get 1, 2, or 3 requests for a medical student to rotate with me. And now we're getting more than we can take on, which is really great to see. And from the medical school and the PA school and requests to speak at other schools. So people are getting interested, and that's good to see. I think the needle is moving, and we're going to have a healthcare workforce that's going to be tackling this issue better than we have in the past. I think there's still work to be done, in terms of prevention and health services and implementing them effectively based on best evidence. And I am really excited about this area of psychedelic science. There have been some pretty impressive early results with use disorder. It's an exciting and fairly new piece of science to be involved in. So I'm excited to see the direction that starts going as well, and hopefully helping folks.
Yeah, well, Dr. Kaplan, as you asked the question, what came to mind to me was when the Center for Tobacco Research and Intervention was established at the University of Wisconsin in 1992. At that point, they told me that a center stays in business and is established only if it has an endpoint. It has a goal that it has to achieve in order to do a time-limited activity. And they told me that the endpoint established for the center I was starting was the elimination of tobacco use in the United States. And I thought, well, I'm going to have a job for the rest of my life and probably the life of my children as well. Thinking that we couldn't really eliminate tobacco use. And I actually believe we can do that now. I believe that with the policies that I described, taxes, media campaigns, indoor air bans, reducing the nicotine content of tobacco to non-addictive levels, and at the same time offering everyone who uses tobacco now help quitting, that we can do this. I think we can do this potentially by the end of this decade. And that would be a wonderful capstone to my time here to be able to contribute to that.
Great. I want to thank both of you. You were just fantastic panelists. It's why I enjoy hosting these shows, is just listening to great people as yourselves. I want to thank our audience for joining us this evening and for your great questions. I hope you enjoyed tonight's program and that you'll continue to tune in for our next Wisconsin Medicine program on Wednesday, May 5th, focused on breakthroughs in biomarker imaging. You can sign up to receive reminder emails and watch past sessions at wiscmedicine.org. Thank you for your interest, and on Wisconsin.